Josh is an international expert on multiple aspects of CMT and predominantly works with children in Sydney and Melbourne, having trained as a podiatrist and a PhD in physiatry or physical therapy, and really brings an important perspective on aspects of CMT. So it's been exciting for us to have Josh present over the last few days, and we've really benefited by having him here. And I'm trying to turn this off. Yep. There you go. And welcome Josh to the stage to bring us up to date on things that he's doing with children with CMT in Australia. Perfect. Thank you. Great. Thanks, Josh.
Thanks very much, Dr. Day. It's been a pleasure being here for 3 days so far at sunny Stanford. It's like the best weather in the whole world, so you're very lucky. And yeah, I've learned a lot about all the wonderful things that is happening here at Stanford, particularly caring for those with CMT. So I've been working in the area of CMT research and clinical care now for 15 years, and I come from a clinic in Sydney. And so I thought I would share with you some of the things that we're doing in Sydney and Australia, but also as part of broader collaborations with doctors and scientists in the US, Europe and the UK. I'm really going to focus on how we measure CMT in order to manage it better, but I'm also going to talk a little bit about some of the management studies that we've been involved with. Okay, so Sydney. Has anyone been to Sydney? Oh, wow. I think more people have been to Sydney than Sydney have been to Stanford. That's impressive. So this is beautiful Sydney Harbour. I'm sure you all saw, hopefully, it looking this beautiful when you were there. So Sydney University is just on this side of the Harbour Bridge. I live sort of a bit that way, quite a lot further that way. And then I also, our University of Sydney here is just sort of in the centre of Sydney. This is our open day last weekend with new students. The university has 50,000 students, so it's a big university. And then our children's hospital is called the Children's Hospital at Westmead, and that's about 20 miles west of the city, just near where the Olympics were held in 2000, which is the geographical centre of Sydney. And that's a pretty large hospital as well. So we have 16,000 staff, so it's a big hospital, and we're joined up with an adults hospital there as well, and there's over 3 million patients come across the precinct each year. So we have a slightly different healthcare system to you guys. It's all free, and so there's a lot of patients. All right, so here's our most famous rugby league player at the Children's Hospital at Westmead, because he was an ambassador for our hospital. And some of you might know him as a slightly different player now, who's just been signed up. Just been signed up for, I don't know if you've heard of this team, San Francisco 49ers. And so he had his first game, I think, last week. And his second game, hopefully, although it didn't go so well the first game, but hopefully the second game will be tomorrow. Jared Hayne. I think you call him the Hayne plane. I don't know where that came from, but that's a whole new name for him. So the Hayne plane. All right, so here's our CMT research group in Sydney. So we've got quite a large number of people interested in helping children and adults with CMT. We have a range of neurologists and geneticists, as well as scientists, nurses, and allied health professionals. There has been quite a lot of CMT research activity in Sydney for over 25 years. We have Professors Garth Nicholson and Robert Ouvrier, who have been working in this area for a long time. And so lots and lots of people have done their PhDs and their postdocs and their fellowships and learnt a lot from these two experts that are just located 20 minutes apart in Sydney. So there happens to be a really large area of expertise. We have a very large clinic, and we tend to know a lot about CMT. Okay, so the talk today is really just to give you an update on what is CMT and the genetics of it and how it's getting more and more complicated. I'll give you a rundown of how our Sydney CMT Clinic is run, and then I'll focus the remainder of the talk on how we measure children and adults with CMT better and also manage. All right, so Charcot-Marie tooth disease, this was the original photograph from 1886, looking at the foot deformities primarily in those with CMT, and also the weakness or the wasting of muscles below the knees. And you can see, interestingly in this case, that one of the feet is quite high-arched, and actually one of the feet is quite flat foot. So it's quite an interesting presentation where one side of the body is very different to the other side of the body. We've since learned a lot more about CMT, and generally speaking, both sides are quite similar. And as you know, many of you get very high-arched feet. Okay, and so this is a particularly severe case of high-arched feet in a young child with CMT. But what we generally see is most people with CMT get a high-arched foot, or we call pes cavus, but also there's a subset that get quite flat feet, which is actually quite interesting. And that can relate either to the CMT type or some other things that we don't fully understand yet that we're trying to work out. However, there is about 4 or 5% of people with CMT that still have that asymmetry where one side is much more affected than the other side. So we know that CMT is affecting the peripheral nerves, not so much the central nervous system, and in the peripheral nerves it's affecting the myelin and all the axons that essentially make the nerves work. So it's not a disease of muscle per se, it's of the nerves that tell the muscles what to do. We know it's hereditary, so we have lots of families coming on to our clinics where multiple people in the families are affected. In this particular photo, we don't get all of our families to stand in funny poses like this, but sometimes it's useful to have a look at their feet, and you can see on the left here is not the clearest view for you, but on the picture on the child on the left is the youngest child, and the middle child, and the elder child, and then the mother. And you can see that their pes cavus, or their high arch foot deformity, is getting higher as the family gets older, and also a bit of foot drop. And for those astute in the audience that are seeing, hold on, the second child from the left doesn't seem to have a very high arch foot or foot drop. It's because she doesn't have CMT. And so in families, it affects people either autosomal dominantly, where about 50% are affected, or recessively, where it's a lot more complicated. So in this case, 3 out of the 4 people are affected by CMT. And we generally see all of the families at all of our clinics like this. Most of the interest or focus in research on CMT has been around feet and legs, but we also know that hands are affected a lot as well, and some people are affected more than feet. And so we spend more and more time now on assessing hands carefully and trying to come up with therapies to improve hand function. And we're starting to see more and more orthopedic or bony problems, and not so much at the feet, which is a major concern for deformities and surgery. Sometimes the knees, but we're seeing a lot at the hips as well. So hip dysplasia or dislocating hips has also been identified as a problem for some people with CMT, but probably up to around 10% of people with CMT. So we have a new program where we screen for hip problems in kids with CMT to make sure we don't miss any developing hip problem. If we miss it, you often hear stories about people having hip replacements with CMT early in adulthood, which is obviously not ideal. And there's some other things we can do earlier on in life to avoid having a hip replacement so early. So we're looking more and more at all aspects of the body in patients with CMT now, not just traditionally hands and feet, because it was a peripheral nervous system disorder. Okay, this is a bit of a busy slide, but just talks about how complicated the diagnosis of CMT is getting. So this is a timeline from 1886 at the bottom up to 2013, and then the frequency of genes that are being discovered. So about 1991 was when the first genetic type of CMT was confirmed, CMT 1A. And then since then, there's now 84 different types of CMT, which is complicated for lots of people that are working in the CMT space. And it's likely that there'll be 150 plus types of CMT in the next couple of years with genome sequencing and learning more about how genes cause different types of CMT. However, clinically and as patients, how you present to us is often quite similar. And so it's more often a technicality about the specific genetic diagnosis. It's actually more important what your problems are and how we can help. However, for clinical trials, this information can be really important to know exactly what diagnosis you have. So when a clinical trial comes along for a specific type like CMT1B, we know that you've got that particular type and you can participate in that particular trial. It also has some bearing on prognosis of the disorder that we'll get into shortly. Okay, so here's some of the members of the CMT Clinic in Sydney. It was started by Professor Robert Ouvrier in the middle, and then now it's run by Dr. Manoj Menezes on your left there. We also have an occupational therapist, a physiotherapist, a geneticist, a social worker, a podiatrist, an orthotist, and a couple of fellows visiting as well, and a rehab physician. And it's a unique clinic in that everyone is in the room at the same time. So we have like 10 doctors and the family all in one big space at once talking about how the CMT is going for the family and the patient affected and how we can help. This type of clinic has been going now for about 20 years, 18 or 20 years, and we have over 200 children with CMT attending this clinic, so it's a really big clinic, and from all over Australia, so it's the only one in Australia like this, and we see patients from all over Australia, also New Zealand and Asia as well. And then the process really is as a diagnostic clinic where you come along and work out if you have CMT and what type of CMT you have, and then you go into the management clinic where you see all the doctors, and then there's opportunities to be involved in research, either clinical trials or looking at gene discovery type projects, and we also have some studies relating to imaging and different nerve conduction protocols and things like that. And we're part of the Inherited Neuropathies Consortium, which is a group of CMT research clinics all around the world, which Stanford is part of, and these are centres of excellence donated by the CMT Association. So we have the clinic in Sydney, there's a clinic in London, and also in Milan, and then the remaining, I think there's, well, I don't know how many there are, 12 or 14 CMT clinics in the US. And we all collaborate meaningfully. We all measure the same things in all patients, we all assess patients the same way, and we communicate regularly about how patients with different types of CMT are going, what particular therapies or interventions seem to be working, and we have a lot more information now to give guidance as to how the CMT is going to progress and to give you a heads up when new treatments come along or new trial opportunities come along. And so it's a really wonderful thing that we're all on the same page now, and this was maybe 6 or 7 years ago. We were all working very separately. A good example was the vitamin C trial. There was a big vitamin C trial for CMT1A. There ended up being eight different randomised controlled trials run all over the world, which were all essentially doing the same thing, but in 8 different places. So it was an expensive, inefficient, unproductive way to do clinical research. Now, if we ran another vitamin C trial, we would have one trial across 17 or 18 sites, which is a much better way to do research. Okay, so I'm going to talk a little bit now about measuring CMT, and then we'll get on to management. All right, so the philosophy around why we need to measure well and measure carefully goes back to Lord Kelvin. So to measure is to know. If you cannot measure it, you cannot improve it. So one of the big studies we've been running in Sydney is called the 1000 Norms Project. And this particular study is looking at 103 clinical measures, so things like strength and flexibility and balance and sensation and a whole lot of biomechanical things to see how you walk, and also quality of life. But in healthy individuals aged from 3 to 101 years, we've collected 1,000 people that are healthy, so we get a much better idea of what the range of healthy is. So when patients come along who we suspect has a problem with weakness or suspect has a problem with strength or sensation, we have very clear guidelines now as to what the normal range is and what the abnormal range is. Normal is a terrible word, but it's quite a helpful word to delineate why it's important to get reference values like this. And so we recruited the last 2 participants, 2 16-year-olds, in Sydney yesterday. So Marnie and Jen, who you can see in these pictures here, have just finished recruiting 1,000 people. So it's a really big deal. And this information helps us come up with better scales so we can measure exactly how your CMT is going compared to people that don't have CMT. And also when we assess new treatments, we can see how effective those new treatments are, not just relative to having CMT, but relative to those without CMT, which gives us an idea of the size of the treatment effect and to make sure that the treatment effect that we see is large enough to matter. In other words, the treatment effect is meaningful. So to give you an idea why it's useful to know this information, this is a figure of foot alignment. So something called the foot posture index, where you can see here a -12 is like those really high arch feet that I showed you in that first picture. So the highest of high arch feet you can get. And a +12 is really, really flat feet. All right, so that's the range of feet that we can measure. And 0 is sort of a neutral foot. So not high arch, not flat foot, somewhere in the middle. And the red dotted line is the range of 1,000 healthy people. Okay, and you can see that the healthy range is a slightly flat foot, a bit of a flat foot. Not really flat, but a little bit flat. And then the black bars are actually the 520 children with CMT. And we've been able to measure the foot posture index in 520 children with CMT. And what we would expect, or what we would think, is that most of the kids with CMT have this really high arch foot, then they're all down this end. But as you can see, they do have a left shift where, generally speaking, children with CMT have higher arches, but there's actually a whole bunch of kids with really flat feet and only a few kids with really, really high arch feet. So it's important to actually know the spectrum of what CMT produces and not just what the internet says or not just what people that don't see many patients with CMT say. The spectrum of foot alignment is ranging from the flattest to the highest arch, and overall isn't actually that different to the average range, which is quite interesting. So it means very different things in terms of treatment. So there's a whole bunch of children here that probably don't need orthotics and need other things to focus on improving their feet, whereas there is a certain group that would really benefit from orthotics. So it's not the same treatment for everybody. Okay, so how the 1,000 norms gets integrated into how we assess kids with CMT this is one example, which is called the CMT Pediatric Scale. And this is a standardised way of assessing the severity of CMT in children aged from the age of 3 to 20 years old. And this particular scale is being measured in all sites of the Inherited Neuropathies Consortium. So I was here this week training the doctors here, and it now will be used in 17 sites across the consortium. So every child is being assessed exactly the same way. So we're all talking the same language. We're able to clearly work out how CMT is affecting your child. And then ultimately, when treatments come along, we can see the effect of that treatment on the measures that matter. So the types of measures we collect in this scale are related to things like hand dexterity, so turning over blocks and moving pegs as quickly as possible. Also looking at how strong grip strength is, and also foot strength, pushing down and pulling up, some things you'll all recognise as quite difficult in CMT. We're also looking at sensation, so this is the least popular test, looking at pinprick, particularly in kids, and also vibration to see how you can sense the tuning fork. We have some tasks such as heel walking, which is almost impossible for most people with CMT, and also toe walking and looking at foot drop. And then we have more dynamic tasks like balance. We have quite a stringent way to assess balance in a standardised way. We also have long jump, which is quite an exciting test, but a scary test for some people because it's quite dynamic to see how much power can be produced. And then we have the old favourite, the 6-minute walk test, which is a really good measure of fatigue. So all 11 items can be conducted in about 25 minutes, and then we put together all the measures that then get compared to an age and sex matched individual without CMT or group of individuals without CMT. So if a 4-year-old comes along, we compare those measures to a 4-year-old that doesn't have CMT, a male 4-year-old that doesn't have CMT. When you come back the next year, we compare them to a 5-year-old and compare them to a 6-year-old. So it actually changes, the scores change with normal growth and development independent of CMT. So we can clearly track how CMT is going separate to just getting older and stronger. All of this information now is online, so the doctors can put all the information straight into a computer program that can automatically generate the score, and then we end up getting a score between 0 and 44, with 44 being the most severe and 0 being essentially unaffected. So to give you some examples of the type of output or data we get from big groups of patients with CMT, so this chart here is looking at the most common CMT types. So type 1A, 1B, 2A, 4C and X-linked, and looking at the overall score out of 44. So you can see that CMT 1A is generally less affected than 1B, 2A and 4C, and then X-linked is actually a little bit less affected than 1A. So that information is helpful in terms of working out how your particular child or you are going with a particular type of CMT you have. We also have information about how each type of CMT goes on each of the different tests. So this particular chart here is probably really hard to see, but we can point out that, for instance, if you have CMT 4C, you have much more problems with hand dexterity and balance, but if you have CMT 2A, you have much more problems with grip strength and things like that. So it helps us come up with better targets for treatment and not just treat all kids the same way with a diagnosis of CMT. Everyone's different, every type of CMT is different, and every individual with that type of CMT is different as well. And 2 weeks ago it was translated into French, and so there's even more users of the scale now in Paris and Marseille, and also in French Canada. Take my word for it, it's accurate, but I couldn't actually tell you what it means. Okay, and we've just started looking at an even younger version, which is the infant and toddler scale, which we're going to look at validating here at Stanford as well as other parts in the US, where we're looking at infants and toddlers aged 0 to 3. And so this is like the most challenging group in the world to assess. So there's only a particular small number of clinicians that are able to do this well, or even want to do this well. And so we've come up so far with 27 items that we think are important for this young group, and they're mainly observed items, so they're not things like strength testing or sticking pins in them or anything. It's much more about how they walk, how they get up from the ground, how they roll over, how they draw and things like that. And so we're ultimately looking at this scale being reduced to about 15 items or so and take about 15 minutes to do. And this will be important when clinical trials come along that want to target the disease at the earliest stages and try and prevent any subsequent problems that happen with the disease by looking at a very unaffected group of patients. And this is being led by Melissa Mandarakis in Sydney and Orani Samachene in Bangkok in Thailand. Okay, so we have the opportunity to look at CMT even more precisely and carefully using 3D gait analysis. So we have a gait analysis facility in Sydney, and I saw your wonderful one here at Stanford yesterday. And we use this type of facility to see exactly how CMT is affecting the way you walk. And we can look at that at a very minute level. So we can look at how the ankles are affected, knees, hips, spine. We can even look at it within how much the lower leg rotates, the upper leg rotates in very specific ways. And so here's the group of engineers and physiotherapists that we work with in Sydney on the left, and then the orthopaedic surgeons and the rehab physicians on the right. And this has traditionally been a big service for cerebral palsy, but we've now transitioned it into helping children with CMT as well. And so essentially we're able to look at every bone moving during walking. And this is particularly useful for seeing the effects of orthotics, but in particular we're looking at new ways to do hip surgery in CMT and seeing what effects hip surgery have on how the upper legs move, the lower legs move, and the ankles move after surgery. Okay, so it's essentially helping with planning of treatment, but also seeing the effect of treatment. And then we also have a way to look at feet in a little bit more detail with plantar pressure. And so we can see how the load beneath the foot occurs during normal walking like this. And we also have an in-shoe version where we can actually put these sensors, 99 sensors, inside the shoes and see how footwear or orthotics have an effect on the foot. But this particular pressure plate here we're using to see the effect of different types of foot surgery, to see what effect it has on pressure distribution and pressure points, which relate closely to pain. And finally, in the measurement space, we're getting more and more interested in ways to assess the muscle itself. So we're really interested in the functional consequences of weakness, like walking and jumping and balance and all those things, but we're also interested in coming out with ways to measure the muscle itself even more accurately. So if there's certain treatments that target the muscle primarily, we can look at the effect of that treatment more specifically. So MRI is looking like the best way to do this. I was fortunate enough to see your new neuroscience centre yesterday with the most beautiful MRI I've ever seen, and also you have an MRI PET combination scanner, which is absolutely sensational right here. So MRI is a way to look at muscles. It can look at lots of different things, but muscles particularly. And we're interested in MRI because the interesting thing about CMT is that it affects muscles in different ways. So let's think about CMT 1A. You generally have weaker muscles on the front of your lower leg and on the outside of your lower leg, but your muscles are generally okay on the back of your leg and on the inside of your leg. So you have this sort of selective weakness problem, which is really perplexing because it doesn't really make sense as to why some muscles are spared and some muscles are affected. And so we're hoping with MRI to get a bit of a better understanding of, in different individuals, how this distribution of muscle weakness occurs. Because when we have feet like this, which we typically think that the stronger muscles on the inside of the leg tend to pull against the weaker muscles on the outside of the leg. And that's why we have a foot deformity like this. Whereas some people who have flat feet generally have weakness similarly on both sides of the leg. But to get a better understanding of the evolution of foot deformity through things like MRI measures will help us hopefully head it off at the pass, try to prevent this foot deformity from ever happening in the first place by targeting the weaker muscles with exercises and stretching and potentially other therapeutic regimes, rather than a generalised exercise program that's actually quite non-specific and tends to strengthen the strong muscles and the weak muscles stay weak, which leads to more imbalance. So we've got a technique now where we can threshold out all of the fat and bone and non-muscle material, and so we just get a measure of muscle or muscle volume. And what we've found so far in the 60 children with CMT who have had MRI and muscle testing and gait analysis done is there's quite a good correlation between the amount of muscle you have and then also how strong you are, but how well you walk. So it looks like quite a meaningful measure. All right, so for the last 10 or so minutes, we can talk about the management side of things. This is the important bit. We spend a lot of time diagnosing, a lot of time measuring, but ultimately we want to spend most of our time managing. Management of CMT is complex in that there's lots of different things to work on. You know, it's not just a high arch foot, there's also weakness and balance problems and pain, cramps, all sorts of different things that people have concerns with. So our treatment programs have been fairly systematic in that we've looked at individual problems one by one. But ultimately we want to start looking at combined therapies to improve lots of different aspects of the disease in one go. So I'm going to start with foot orthoses because that's where I started my research journey or career back in 2002. During my PhD we looked at high arch feet like this in a whole range of people, not just in CMT, who had a lot of pain in their feet due to those pressure points. So some people get calluses, some people get a big build-up of bony tissue or swelling at that point, and essentially because the high arch foot doesn't have much contact with the ground, you get these pressure points and you get subsequent pain, and pain is significant, as you know. For those with a high arch foot and pain, we look specifically at a device that goes inside the shoe to redistribute pressure. And we looked at a device that is customised to your foot and a device that's just a flat, thin material that's not customised. And as I was talking about before, we have pressure machines that can measure pressure inside the shoe, and we use this in-shoe pressure system to measure the effect of the different orthotic types on the pressure distribution beneath your feet. And you can see here that this particular image shows the high pressure points beneath the big toe. I don't know if I have a pointer. I don't think I do. Yes, I do. We have pressure under the big toe here. We have high pressures under the heels. We have these high pressures under the midfoot. So you can probably all identify with those areas of pain, and not much of the middle of the foot in contact with the ground. And then with the customised in-shoe device, you can see we start filling up the middle of the foot there with a bit more contact, and the pressure reduces at the heels and the forefoot. So we're able to reduce pressure by 80% with this type of orthotic device, and subsequently reduce pain by 70%. They were very effective for people with high arch feet and foot pain. But as we know, there's lots more to do with CMT. And so where we're up to now is looking at all the different types of orthotics, because many of you wear orthotics in this room, many of you have family members that wear orthotics, and it's quite a complicated range of devices. There's the small ones, there's the medium size, halfway up the ankle, there's the ones all out the leg. There's thick plastics, there's carbon fibres, there's some that have a hinge, there's some that are sort of springy, there's some that are really solid, there's ones that actually go over the knees, there's all sorts of different types. And we've done a little bit of work to try and work out an algorithm or a recipe as to what device to prescribe to who, but there's a bit of a technological lag in actually trying to get the best device made for the right patient. Plus, a lot of these devices are not all that attractive, and kids in particular aren't always that happy wearing them. So in Sydney, at least, we have a long waiting list to get orthotics made, up to 6 months. And then when we get them made, only 50% of kids actually wear them. So because they hate them. They're hot, they're heavy, they look disabled, all these things that we know all about. And we're trying to make a device that's more acceptable, a bit more specific to the problem that the child has, and not sort of a generalised approach, and come up with better ways of doing orthotics. So one solution, or one idea, is using the new technology, which you probably all know a bit about, and that's 3D printing. So the idea with 3D printing is to rapidly make devices that are specific for the patient's needs, and also make devices that are not as bulky, not as thick, not as heavy, not as hot, and including the patient in the process to make sure we make a device that they're willing to wear. So 3D printing gives us this immense flexibility in how we can make these different devices, and they can be made in a very rapid turnaround. So for us, we're at a point now where we can make prototypes of orthotics in about 12 hours, whereas currently the pipeline for orthotic therapy at our hospital is 7 months. So straight away, we've at least got the time differential sorted out. The next thing is to actually do some head-to-head trials on the traditional types of orthoses versus the new types. So this is our first AFO being printed on a 3D printer. And it's obviously high speed because it takes a long time. But you can see that essentially you take an impression of the foot with a 3D scanner. You then manipulate the image on the computer, and then you send it to the printer and press print. So it's pretty exciting what we can do in this space. And we're also using 3D printing for different types of orthopaedic implants and trying to make a lot of the hardware that we use in surgery a little bit more acceptable. But for orthotics, we're really excited because we've got all these new materials to trial. We can look at different plastics, we can look at different metals, different carbon fibres, different rubbers, different paddings to try and make things better. Because ultimately, we can make a device like you currently wear, but we want to make them better. So ultimately, we want to come up with new, exciting designs that are much more comfortable much less adverse effects, much more responsive to your needs, and replaced regularly. And then because we have that 3D biomechanics lab as well, we can test the effect of the device that's made in 12 hours, which hopefully will get down to 1 hour, in the lab downstairs. So the vision, and we can have visions at Stanford because anything is possible, is that we'll take a 3D scanned image of your foot and leg from an iPhone. We'll send the image file up to the engineers in the 3D print lab, and then about an hour 10 later, the orthotic will come down for the patient. And if it's not right, we'll just print it again. And so within the day, within a couple of days, you'll have a device that works for you because we'll test it, we'll make sure it's comfortable while you're here. So the opportunities there are really exciting and really fun. And we're trying to get beyond the hype now and get some science into the space and involve patients in the journey to make them as good as they can be. All right, so stretching and strengthening is a big part of what we do. I'm sure many of you have been given stretching regimes and even some exercise and strengthening regimes that are not always effective and not always enjoyed. And so we spend a bit of time on trying to come up with more interesting and enjoyable and effective ways to stretch and strengthen. Now, this is one solution which came out of the idea that at one end of the spectrum, you have like the static calf stretches where you like lean against the wall and you stretch your calf, and you can only really get about 1 or 2 degrees of range by doing that. At the other end of the spectrum, you've got these serial casts where you have these casts applied to your leg with a big stretch on your ankles, and you wear these casts 24 hours a day for up to a week, and then they're changed for 3 or 4 weeks. They're sort of the two ends of the spectrum of stretching. So the serial casts are hated by lots of patients because they're really limiting in function, they're really hot and they don't like wearing them. But the stretching against the wall doesn't really work that well. There's some night splints that some people wear where you get a stretch just at night time that are prefabricated, but often they sort of work their way off overnight, and we found in a trial that they weren't very effective either. So we've come up with this sort of compromise, which is a night cast, which is a serial cast where we give a really big stretch to your ankle and we plaster cast it all over your leg, and then we put bivalves or cuts in the plaster and some Velcros. And so you get that super big stretch, but you're just wearing it at night time. And this type of stretch can increase flexibility of the ankles by 5 degrees in 4 weeks, which is quite a lot, and it can maintain it for about another 4 weeks after that. So it's not as good as serial casting, but it's much more acceptable, and it also improves walking speed as well, which is what it's all about. Strengthening is where there's a lot of interest. So because your muscles are actually okay, but your nerves are not so good, there's a lot of opportunity to strengthen the muscles themselves. A lot of weakness in CMT is actually thought to be about deconditioning. So your muscles just not being given enough load or enough to do, much like everybody. We just don't do enough physical activity, full stop. And so a lot of the strengthening idea is about reconditioning your muscles, irrespective of having CMT, but obviously when you also have CMT, there's more gains to be made. So we're doing a big trial at the moment where we're specifically looking at the muscles on the front of your lower leg, the dorsiflexors, the ones that cause foot drop. So these are like the most effective muscles in your legs with CMT. These are the ones that cause the foot drop, cause the tripping, cause the high stepping gait, and a lot of the problems that people with CMT complain of. So we have this specific targeted muscle strengthening program now where we add weight to this apparatus as you get better. So every 2 weeks we progressively increase the weight a bit more. So over 12 and 24 weeks you're lifting as much as you can. And we're doing a big trial now to make sure it's safe, and then hopefully it also dramatically improves your strength. So we did some pilot studies here and we found that we could increase the strength of these muscles by 70%. So a really big amount of strength training. The problem is it's also a bit boring. So ultimately we need to come up with more interesting ways of doing it. Maybe we need to get the Wii Fit out or some sort of PlayStation game and make it more interesting. But at this stage we're trying to make sure there's a proof of concept here that we can actually strengthen your muscles significantly. And we also have a study of adults looking at generalised aerobic activity at gyms to see if going to the gym can improve your strength, balance, function when you have CMT. which we think it probably can, but we need to do a randomised controlled trial to make sure it's safe and make sure it's not going to do more harm than good. There's some concerns in other neuromuscular disorders that if you do too much strength training, you'll actually become weaker. So we need to make sure in a careful trial like this that we're testing not only if it works, but also that it doesn't make you worse. I'm going to talk a little bit about surgery. If you don't want to see pictures of surgery, you want to look away now. I've got 2 pictures of surgery that can be a little bit confronting. So one is foot surgery, and so for 15 years we've been doing increasing amounts of foot surgery in children with CMT. And the reason we've been doing increasing amounts of foot surgery is because we have the head of orthopaedics that comes along to our CMT clinic every 2 weeks. So we're actually all on the same page now. We're working really closely with orthopaedic surgeons to work out what the best type of procedure is, to get the timing of the procedure right, and to try and do a lot less bony surgery and a lot more soft tissue surgery. So in this particular photo here, you can see one of the muscles on the inside of the leg being transferred to the outside of the leg. And that's to rebalance that muscle imbalance I spoke to you about before. But this type of surgery is only useful in certain types of CMT. You're not going to do this surgery if you have a CMT type 2, for instance, or if you've got flat feet. So there's actually specific surgery required for specific types of CMT, and that's actually quite subtle to most orthopaedic surgeons. So being able to work really closely with an orthopaedic surgeon is a great way to get the surgery done better. But also what's really important, and you've seen all the things I've spoken about now, and measuring things carefully, is also to look at long-term outcome studies of doing surgery. Because we hear terrible reports of lots of surgery done that has been debilitating, causes more pain, causes more disability, has been an absolute nightmare for people. Historically, a lot more surgery was done on bones and joining bones together and cutting bones in half and really, significant and severe procedures. But as we work more and more with soft tissue procedures, we tend to have less long-term adverse effects, less early stage arthritis, and a bit more function. But what's fascinating in orthopaedic surgery is we did a survey last year of 17 orthopaedic surgeons around the world who talk about being specialised in CMT, or at least seeing quite a lot of patients with CMT. And we gave them a scenario of a high arch foot deformity with certain elements like we've talked about today. And out of the 17 surgeons, there were 16 different recipes for surgery. So 16 different procedures were recommended for that one particular patient. And so no matter how many opinions you get, you're not going to get to 16 different opinions to get consensus. So there's a bit of a problem out there in terms of knowing what to do with surgery. So next year we're going to have a big meeting of 20 surgeons all around the world and work, I think, tirelessly for 3 days to get consensus by the end of that 3 days as to what we're going to do for 5 different types of patients with CMT. So then we can publish a document that everyone can see, that the 20 surgeons in the world who know about CMT recommend A, B, C, D, E for those 5 different types of patients. So we think that's going to be a really big step forward for the field and hopefully help many of you who have thought about surgery or struggled with surgery or have children that are considering surgery to try and get the best outcome possible. Because randomised controlled trials in surgery is really, really hard. We can't sort of have a no treatment or a placebo treatment for surgery. And we can have 2 types of surgery, but again, we need to know how each one works. Hands is also a big deal as well, and there looks to be more and more opportunities to do tendon transfers in hands. And we've done a little study at Philadelphia looking at 3 children with really, really weak hands and found that tendon transfers improved their dexterity and their strength significantly. So there's a little bit of information there about how to help children who are looking to have surgery for their hands. All right, so to finish up with what we're ultimately aiming to do with all of this research and all of the measurement techniques I've talked about is come up with simple practice briefs. The idea here is that we have a 2-page pamphlet that is either available online or available through an app or available through the CMTA or wherever, that can go along to you when you see your doctor or see people that aren't experts at CMT to help them understand what CMT is and the evidence around certain aspects of care. So this particular one's about orthotic therapy for children with CMT, and this gives all the information that is available in the literature, all the information I've talked about today, but in a simple 2-page pamphlet. And ultimately what we want to do is we've set up a standards of care or a best practice guidelines committee around the world, and we want to come up with a pamphlet like this for each of the different problems that people with CMT have. So if you've got hip problems, if you've got cramps, if you've got foot deformity, you can pick the pamphlet that suits your problem and take it with you when you see different health professionals, which, you know, unlike the great clinics you have here, there's a lot of places out there that don't know all that much about CMT. Thank you very much.